welcome to my YouTube channel. Myself as Dr. Monu Nain. I am currently pursuing my post-graduation in general surgery from Jhalawad Medical College, Rajasthan. Today our topic of discussion is intestinal obstruction. The reference for the information shared in this video is from Love and Belly textbook of surgery. So let's get started with the topic without any delay. I will try to make this session more easy and understandable with coverage of all the important questions asked in recent exams with pictures and example. So let's get started with this topic. So intestinal obstruction is mainly of two types, dynamic and adynamic. What is the difference between dynamic and adynamic? We try to understand in a simple form. Let's assume this is our intestine, its wall. So in dynamic there is a mechanical obstruction which can be present in the lumen of bowel. Let's assume in the lumen, in the wall of bowel, or outside the wall of bowel. So there are three types of mechanism which can cause obstruction in dynamic obstruction: in the lumen, in the wall, or outside the wall. So in the dynamic obstruction, the peristaltic mechanism are intact as written in the slide. So this peristaltic movement exaggerate in dynamic type of obstruction which tries to overcome this obstruction. So there is exaggeration of peristalsis which try to overcome the obstruction by any way, which so there is presence of bowel sounds in dynamic obstruction. As compared to dynamic, in adynamic obstruction there is failure of mechanism which leads to peristalsis. So there is, in simple language, there is absence of peristaltic movement. So there is no peristaltic movement, so there is no bowel sound. So by simple use of stethoscope placed at spino-umbilical line, here is umbilicus and here is anterior superior iliac spine, and the line joining the umbilicus and anterior superior iliac spine is known as spino-umbilical line. So by placing the steth over this line, we can have a fair idea between dynamic and adynamic obstruction. If the bowel sounds are intact, then it signs toward dynamic obstruction, and if the bowel sounds are absent, then it can be a adynamic obstruction. But there is a point to remember: the bowel sounds can be absent in late stage of dynamic obstruction, but they are present in early. But here in adynamic obstruction, the bowel sounds always absent in adynamic obstruction. So this is the difference between the two, dynamic and adynamic obstruction. So let's move to the next slide, in which we discuss the cause of obstruction in dynamic and adynamic obstruction. In dynamic obstruction there are mainly three mechanisms I have discussed in previous slide: intraluminal, intramural means in the wall, intraluminal in the lumen, and extramural outside the wall. So in intramural, what things are there to cause obstruction? So there is fecal impaction, means fecal matter obstructing the bowel lumen. It is common in old age with chronic constipation. These are the patients which present in OPD with bowel obstruction, old age. So it is very important for teacher or resident to do a PR in intestinal obstruction. It is the importance of PR. So can we evacuate the fecal infection in rectum which cause obstruction of large bowel? This is one point. And foreign body can be common in children, or it can be worm. For example, ascariasis. So there is an important point. So we have to send stool sample, or there can be history of passing worm in stool. So these are 2 points. One, we have to send stool sample to rule out the worms, or we can ask about the passage of worm in stool. Third one is very important from NEET PG perspective, bezoars. Bezoars mainly of two types, phytobezoars and trichobezoars. So phytobezoar mainly from plants, and in trichobezoar mainly hairball. If you remember, there is a question NEET PG, a psychiatric patient, history of eating hairs, present with obstruction. What is the name of this syndrome? This is the question in NEET PG. This syndrome. We will discuss this syndrome later in slides. And other is gallstones. How gallstone can obstruct the lumen of bowel? There is one triad named as regular triad. I will also discuss this in next upcoming slides. So what happens? There is our gallbladder connecting with the common hepatic duct, and this is cystic duct continuing the common bile duct and continue here in the duodenum, second part D2. So if there is a chronic cholelithiasis, what happened? This stone erodes the wall and it comes here through a fistula and it passes into the intestine like this, passes. But where the narrowest part, terminal ileum, the stone get stuck at terminal ileum and cause the obstruction of bowel. This syndrome is known as Bowart syndrome. This can be a potential question in upcoming NEET PG. So Bowart syndrome, I will discuss this with the help of abdominal X-ray in upcoming slides. So this is the causes. These are the causes which cause obstruction of the bowel lumen: fecal infection, foreign body, bezoar, gallstone. So in the wall, what are the causes? It can be a stricture. Stricture can be result from trauma, or it can be a tubercular stricture or from a Crohn's disease. These can the causes which cause strictures. It can be a malignancy or intussusception. Intussusception also cause intramural obstruction, which is the most common in children. History of red currant, jelly, stools, and there will be sausage shaped lump These are the points which leads to diagnosis of interoception. And there can be volvulus. We have discussed it later in other videos. Two type of volvulus, mainly sigmoid and sickle. Sigmoid is more common than sickle. Sigmoid volvulus will be here in left iliac fossa and sickle here in right iliac fossa. There are different signs on X-ray, USG and CT which will be discussed later in detail in topic of volvulus. So after discussing the intraluminal causes and intramural causes, we will discuss about the extramural causes. In extramural causes, there is adhesions. This is the potential question, which is the most common cause of intestinal obstruction. The answer will be adhesions. Adhesions post-operative or tubercular or trauma, any of them can lead to adhesions which call intestinal obstruction. Or there can be hernia. Two types: internal hernia, external hernia. So during the examination or history part, we have to ask about the any abdominal surgery or history of TB in intestinal obstruction patient, or we have to examine the hernial orifices during the abdominal examination in case of intestinal obstruction to rule out any hernial obstruction. Understand? So these are the three main headings covering all the causes system wise from inside to outside of bowel which cause dynamic obstruction. For adynamic obstruction, there will be mainly two headings: paralytic ileus and pseudo obstruction. So paralytic ileus mainly due to the following reason: post-operative paralytic ileus means during the laparotomy or another abdominal surgery, if we handle the bowel lose its peristaltic movement temporarily for 24 to 72 hours, which is known as post-operative paralytic ileus, and it can be due to the intra-abdominal infections which can lead to paralytic ileus. It can be due to the metabolic cause or reflex ileus. In metabolic cause, there will be cause of uremia in which urea increased, and hypokalemia. Hypokalemia also cause intestinal obstruction because potassium needs for the peristaltic movement for the smooth muscles of intestine. So here is a catch. So in adynamic obstruction, you always check potassium in biochem report and urea's level. These are the 2 points to remember. And there can be pseudo obstruction, small intestine pseudo obstruction, or colonic pseudo obstruction, which is also known as Ogilvie's syndrome. I am not going in detail here. We will discuss this later in upcoming videos for more details. So These are the causes of dynamic and adynamic obstruction. In the next slide, we are going to discuss very important slide, clinical features of dynamic and adynamic obstruction. So in clinical feature, in dynamic obstruction, I am going to divide it in early and late. In early, there will be pain because due to exaggerated peristaltic movement, bowel tries to overcome this obstruction. So there will be colicky pain in early stage. So colicky pain and vomiting. There will be vomiting in high level obstruction, small intestine obstruction. It is the early feature as compared to large intestinal obstruction, in which vomiting is a late feature. And distension and absolute constipation. What is the meaning of absolute constipation? Means patient is unable to pass flatus and stool, and the term used for this is known as obstipation. So when you are going to ask about the history, you will ask about the pain, vomiting, distension and absolute constipation to make the diagnosis of dynamic obstruction. So these are the early features. Let's consider for 1 or 2 days. After 2 or 3 days, the patient enters in late stage of intestinal obstruction, in which the features are dehydration. So why the patient present with dehydration? Because there is loss of fluid in third space, and patient also has vomiting. So due to these two factors, due to the third space loss and vomiting, patient goes in hypovolemic shock, which leads to effect on kidneys. So there is less formation of urine, which leads to oliguria, shock, and due to this vasodilation, bacteria grows more and more, causing septic shock to the patient. The patient leads to sepsis, and due to the prolonged obstruction, there will be compromise of blood supply to intestine. First of all, due to the obstruction, there is decrease in venous return, which leads to arterial occlusion, and which leads to the ischemia, and later to the gangrenous gut, and later to the perforation. So this is the sequence in which perforation occurs in obstruction cases. So how we know on the basis of history that there is ischemia or perforation going to start in intestine? So we are going to ask about here any tenderness per abdomen, guarding, rigidity, skin changes over abdomen. So on the basis of history, you can know about the status of patient. So during the examination, always look for the sign of dehydration. Oliguria, put catheterization to measure the urine output to know about the status of shock. So these are the things to remember in dynamic obstruction. As compared to adynamic obstruction, as you all know, there is no peristalsis. So if there is no peristalsis, there is no pain. So this is the star point. There is no pain. Patient will never complain of pain in aerodynamic obstruction. He can complain of vomiting, absolute constipation or distension, but there is no pain in aerodynamic obstruction. So these are the clinical features, history point and examination point in case of dynamic and aerodynamic obstruction. And one thing is more important to remember: pain. If the pain is colicky, it is due to the peristaltic movement which tries to overcome the obstruction here. And if this pain colicky in early stages, but in later stage patient complain of dull aching or sharp pain, severe intensity, then it will point toward the ischemia of bowel. When the ischemia settles in, it will lead to sharp pain, severe pain. So it is very important in intestinal obstruction case to know about the character of pain the patient having. So take the history properly. So now we are going to discuss about the diagnosis, how to diagnose intestinal obstruction case. So we will order erect abdomen X-ray in emergency to know about the intestinal obstruction site. So there will be air fluid level like this. Here is the fluid, white in color, and air, black. So this air fluid level will be present in abdominal X-ray. If they are greater than 3, then you can say the patient has intestinal obstruction. So there are different characters and different pictures in 3 cases. Like small intestinal obstruction has different scenario, cecal obstruction different, and large intestine different. I will discuss this in detail in next slide with the help of pictures at the end of all this theory. So in small bowel the obstruction will be central, like here, center, in the center of X-ray. Transverse air fluid level will be seen. For jejunum there will be volvae conniventis, continue till full lumen of the intestine, full continuity, and ileum is featureless, nothing can be seen in the lumen. Cecum has rounded gas like shadow in right iliac fossa, like this. And large bowel has peripheral picture like this, in the periphery, not in center like this, here in center, smaller bowel. And here is the feature of large bowel hostra, incomplete intestinal fold, like this. Volvula conventus complete and hostra incomplete. So these are the features. When we'll do NEET CT abdomen. So CT abdomen is an investigation of choice to diagnose the intestinal obstruction, to know the exact site, to rule out any strangulation, gangrene, ischemic changes. We will order CT abdomen for this. So this is the diagnostic part in intestinal obstruction case. So now we proceed toward the treatment. So in dynamic obstruction, what will be the treatment? So first of all, we are going to conservatively manage the patient, and then after detecting the cause of obstruction, we will do any surgical intervention if needed. So first of all, we are going to put the NG tube, nasogastric tube. Why nasogastric tube? To decompress the stomach and intestine. Then we are going to give him fluid and electrolyte replacement because the patient is already in shock and dehydrated. And we will put catheter. Why catheter? To decompress the urinary bladder and to measure the urine output. And we will keep the patient nil per oral. Why nil per oral? Because there is because the bowel already dilated, there is no peristalsis, so we will keep the patient nil per oral. Here is the management with the explanation and reason behind it. So surgical intervention, we can do operative decompression. If the adhesions are the cause of obstruction, we will do adhesiolysis. It can be done by lab and open surgery. If the bowel is non-viable, means black bowel, we will resect and anastomose the bowel, and we can enter the bowel by exploratory laparotomy, and we can form ileostomy in right side and colostomy on other side. So these are the management steps for dynamic obstruction. In aerodynamic obstruction, the management is quite simple. Only conservative management will be done in these cases. We will wait for 24 to 72 hours. In post-operative cases, post-operative ileus, we will wait for 24 to 72 hours because the peristaltic movement returns in this time of period. We will keep the patient NBM, insert NG tube, electrolyte balance, and we will treat the cause. So this finished the theoretical part. Let's discuss the images which give you more confidence to attempt the questions. So it is the slide showing the causes of obstruction. As I discussed, adhesions are the most common cause, 40%, and hernia, obstructed hernia, 12%. Inflammatory causes like TB, Crohn's disease, 15%, CA, 15%, fecal infection, old age, constipation, 8%, pseudo obstruction, Ogilvy syndrome, etc., small intestine, and miscellaneous. These slides showing the causes. And the next slide, here is the small intestinal obstruction features. I have discussed central you have seen like this, central air fluid levels. These are the air fluid level. This is the air and here is fluid. Air fluid level 1, 2, 3, 4, 5 and greater than 3. Central. So these are the feature of small intestinal obstruction. Central, vomiting, pain. And this slide showing the volvae conniventis, feature of jejunum containing full luminal bowel like this here, containing full in the center. And these are the features of large intestinal obstruction. Periphery, I have already discussed in the periphery, and these are the hostral fold, these are the hostra, these incomplete folds are hostras. So this is the picture of large intestinal obstruction. So I have discussed in previous slide the regular triad in which the gallbladder ruptures and stone enters the intestine and blocked at terminal ileum, most common site. So there will be three things you can see. There is air. Pneumo means air, bilia means biliary tract. Air in biliary tract, this is known as pneumobilia. And small intestinal obstruction, I have already discussed, stone hair obstructing the small bowel too, and this is known as radiopaque stone. You can see here radiopaque, this is gallstone. So these are the three features of regular striate: pneumobilia, small bowel obstruction, and gallstone. And here is the slide showing hair ball in stomach. This is the CT showing hair ball. This is known as Rapunzel syndrome. Psychiatric females, history of eating hair ball, trichobezoar. So here we are going to end this discussion. If you have any queries, please let me know in the comments, and kindly follow our YouTube channel Scrub Squad 2018 for more videos. Thank you very much.